So there were two RESONATE trials. The RESONATE-1 was the first study that led to the full approval of Ibrutinib in relapsed and refractory CLL, and we updated the data this past year, showing that the remissions in that study, and this was presented at ASH, are continuing to be persistent. That patients are doing quite well in both the arm that initially was assigned to Ibrutinib and the many patients that have crossed over. And the value of that study, other than showing the significant benefit of Ibrutinib, was identifying relatively uncommon but present adverse events such as atrial fibrillation and bleeding that in most patients is not clinically significant, but in a subset it is, and it calls attention to side effects and the need to manage those appropriately so patients can be on an effective drug. RESONATE-2 was just published in the New England Journal, and I would say that's a land-breaking paper, because even though the study used it's a phase 3 study, it used a very, very weak control regimen, chlorambucil. And really you could have used any therapy that we give in CLL, and the results would have been the same, because the Ibrutinib patients have done phenomenal. There have been very, very few progressions. The survival curve is essentially flat, and it looks like a survival curve of patients that are age matched without CLL. The study again showed we see atrial fibrillation and some side effects with Ibrutinib, probably in some a little bit more common than chlorambucil, but it's manageable in most, and it's really a paradigm-changing study. It led to the FDA approval for marketing in the U.S., I think, just a week and a half ago. And for my practice, it'll be, say, I'll be looking at my CLL patients, really asking why I'm not going to use Ibrutinib versus which patient am I going to use Ibrutinib, because the results just really look good, and something that I think is going to really change completely the landscape of how we treat CLL in the U.S.